So firstly, thank you very much, Professor David Blumenthal, for coming and to London to talk to us about American healthcare reform and for coming to Pennyhill Park. It's a great pleasure to have you. I was going to start off by asking you a little bit about some elements of reform. One element is developing accountable care organisations, which we here would call integrated care organisations. Can you tell us what the main aspects of that reform are, and do you think there will be take-up in the USA?
Yes, well, thank you for having me. Pleasure to be here. The accountable care organization is a core reform in the healthcare reform legislation, and it attempts to get at what is really more accurately called an opportunity for shared savings. The diagnosis of much of the problem, the inefficiency of the healthcare system, is that there's no incentive for organizations to constrain resources or to improve quality. And the accountable care organization is an attempt to use payment incentives and accountability mechanisms to get at that core lack of incentive in the system to improve performance. What Medicare is proposing to do is that if an organization can show savings but maintain quality at the same time, that it will literally share the savings with the providers who are responsible for reducing those costs. And that means that the pain of reducing the volume of services, which is important to reducing inefficiency, that pain is mitigated and potentially turned into a gain. So what is necessary to be successful in that endeavor, once the incentives are lined up that way, is not precisely specified. Many different kinds of organizations, many different configurations of organizations could potentially be accountable care organizations. Integration is likely to be an important facet, but it needn't be integration in the form of common ownership or common location or any kind of legal relationship. It could be virtual integration. Now, there does have to be an ability for an organization to accept payment and distribute it, so there does have to be an overriding legal entity. But there could be many types of payment arrangements within that legal entity, many levels of integration. And I think that the Department of Health and Human Services, the Medicare program, really is agnostic as to the organizational type, as long as it meets the minimal requirements of the regulation and the law. So is it transferable? I think it could be transferable. I think it is a solution to a problem common to all modern healthcare systems, which is how to be efficient and coordinated and preserve quality and measure it and perform to the information and in light of the information that's available about the care that's being provided.
So are accountable care organisations likely to be networks of providers, or could they be plans or what we would call commissioners attached to them, or a mixture of both?
The law actually requires that an accountable care organization be an organization of providers. So it's not going to be possible for a plan, an insurance company, for example, to apply to be an accountable care organization. So that's fairly specific. And I think that the concept here was that the lack of organization in our system is most acute at the provider level, and that the ability to create accountability rests significantly in the hands of providers of care, clinicians, and to get them to participate in this change in culture, change in attitude towards service, trying to reduce the numbers of services, or at least make them reduce the unnecessary services, and to make sure that they participate in the benefits that are generated by that reduction in the level of service.
You talked about shared savings being one aspect of financial incentives that might operate inside these provider organisation. Are there other financial incentives that you think also will operate within them?
Right now, the only one that I am familiar with and that I think is contained in the regulation is a schedule of shared savings. And I suppose one might also add to that shared risk. After a certain number of years, the way the regulation was originally written, organizations will be sharing risk as well as savings. And there's an opportunity in the original regulation to do that right at the beginning if you feel ready and able. And the regulation allowed for higher savings, higher participation in savings, if you also shared risk. So there was a slight advantage if you had a positive result, if you were also willing to share the downside from a negative result. Now, that was an interim, a proposed regulation, and I don't know what the final regulation will contain. It was one of the contentious parts of the regulation. That is that the risk was going to be a required component of the incentives further out.
And how can we be sure that the amount of risk that these organisations take on is appropriate for them? The Nuffield Trust has just published an essay by Larry Casalino where he talks about the demise of various medical groups over time, and one of the key factors has been that they took on too much risk that was appropriate for them, and therefore suffered deficits.
Sure.
How is that risk going to be calculated appropriately?
Well, I think there's going to be a lot of experimentation over time, and one of the reasons for postponing the risk until several years after accountability was participated, that is, accountability took shape, I think, was to enable organizations to develop the systems that they need to manage risk. We know it's possible to do. Personally, I think one of the critical elements in risk management is information, and that the availability of good information, presumably through good electronic systems, is going to be a kind of a essential condition of effective participation. So I think that, I don't know whether, I haven't read the paper, but I suspect Larry is talking about the experience of the 1990s under managed care. And I think a fatal flaw in that time was the absence of any reasonable information about resource use or outcomes of care. I think given the current progress toward electronic systems and the incentives to adopt electronic systems, that 3 years out, when risk becomes real under the proposed regulation, that organizations will be much better situated to manage risk than they would have been 10 years ago.
Now, you've held a very prominent position in encouraging the use of information and the electronic medical record and interoperability. What particular incentives have been promoted to try to ensure that more physician groups have this kind of electronic information on which to handle risk? Sure.
Well, before the passage of our health reform law in the United States, in February of 2009, that is about a year, over a year before the passage of the law, of the Accountable Care Act, the administration and the Congress passed, enacted something called the High-Tech Act, which set aside up to $27 billion to incent the adoption and meaningful use of electronic health records in the United States among providers of care. And those incentives are now available. The federal government has already paid out close to $300 million, and close to 70,000 providers have registered with the Center for Medicare and Medicaid Services to become meaningful users. So we have a impressive set of opportunities, incentives available. A physician can get anywhere between $44,000 and $64,000 over a 5-year period if they're a meaningful user of electronic health records. Hospitals can get millions of dollars from doing that. So it's a new world in the United States with respect to electronic technologies. Now, there's a difference between having it and using it. Having it doesn't assure that you're able to use it effectively, but it is an essential first step. Now, the timing of an accountable care organization process and the timing of this new incentive system is, I think, remains to be worked out, but at least we've gotten started.